So my job is to talk a little bit about postpartum hemorrhage, and I was delighted because it's actually one of my favorite things to talk about. It's actually one of the really early embolization procedures. Dr. Frank Miller, I wish I had a better picture of him, first described this in 1979, and there have been literally hundreds of studies that you can find in PubMed talking about this and reporting very high success rates. Now, I think one of the things about postpartum hemorrhage is that it is divided into two different sections. One is early postpartum hemorrhage, which is in the first 24 hours following delivery. And then there's a late postpartum hemorrhage, which occurs more than 24 hours and less than 6 weeks after delivery. Now, the causes are different, or some of them overlap, but mostly different. The early postpartum hemorrhage, the most common reason for this is uterine atony. About 80% of this, and uterine atony really is caused by a number of different things, like multiple gestations, makes your uterus really big and it just never can contract down. If you have a really long labor, that can be another cause. There's a lot of reasons that it can be that can be a problem. Also, retained placental fragments. You can have laceration of the lower genital tract, either the cervix or the vagina, uterine rupture, uterine inversion, an invasive placenta. If I have time, I will try and talk a little bit about that, and coagulopathy, potentially from an amniotic fluid embolus or a congenital reason. The causes of late PPH are the retained placental fragments, which obviously is also in the early ones, but then also endometritis, vaginal or uterine tears, pseudoaneurysms, and AV fistulas. And the last two, pseudoaneurysms and AV fistula, I probably won't have time to get to, but if I do, great. Depends on how fast I talk. The therapeutic approaches to postpartum hemorrhage, the first thing that the obstetricians will do, of course, is give an oxytocin drug. They'll do uterine massage. They can then put in a tamponade balloon to try and keep the uterus from bleeding. They will do transfusions, obviously. They'll do a curettage to make sure there's no retained placental fragments. The compression suture and bilateral iliac artery ligation are largely of sort of historical interest, but in a place where there isn't interventional radiology, this in fact may be what the obstetricians might try. Then hysterectomy, and finally we'll talk about embolization. Now, just so that you know what this looks like, the non-surgical option, you can put in this Bakari balloon. You can fill it up with as much as 500 cc's of sterile saline, and it sits in the uterus like you could see here, where it's in the uterus, and you just blow it up. Now, there are a couple of problems with this. Usually the cervix is wide open because she's just delivered, and so the balloon can slip out and end up in the vagina, and that's not really helping at all. But it's a good first step. And sometimes you'll see patients come down with one of these in place for the embolization. And you want to make sure that before you finish, that you take that balloon out and make sure that there's no fresh bleeding. The really important thing about obstetrical bleeding is it's really analogous to pelvic bleeding after trauma. There's a very high mortality rate. It's very difficult to control surgically. You want to do this early and embolize it. And this because you don't want the patient going into DIC, which makes your embolization so much more difficult. The nice thing about it is it can allow for maintenance of fertility, and there's really minimal morbidity with it. So we treat these patients like a trauma victim. We don't wait for them to stabilize. We bring them down, we resuscitate them in the IR suite. They're usually coming down with anesthesia because they've already going through a big deal. And so they will come down and we'll resuscitate them downstairs. We do a pelvic arteriogram, sort of to kind of get an idea of what's going on. And here you can see there's actually, with the purple arrows are the ovarian arteries, which will be large and may or may not be causing a problem. And then this just happens to be one where actually you could probably see the bleeding site here, but we don't necessarily see that. And so if we don't see something, if we seeing this, we would go to the right side right away to embolize that and then come back to the left. The other thing that we might want to notice is how narrow these arteries are. That's because this woman is in shock, and her arteries have contracted down to keep her from bleeding as best that they can. Here's another pelvic arteriogram. Nothing particularly looks too exciting there, and so usually we would just go to the left side to start. Here's a catheter has come down and has selected the left uterine artery, and now you can see the uterus going up, and of course the uterus is going to be big. It's going to be out of the pelvis, so you won't see it down in this area. It's going to be really stretched up, and then we just embolize with gel foam, which is something that hopefully over time will do what we call recanalize. In other words, the blood flow will start going back through there, and that will provide normal blood flow to the uterus following this. Not very often. This patient had undergone a cesarean section and then was continuing to bleed, and they decided that they needed to get a CT to see where it was bleeding from, although I don't really know that that really helped at all, except to waste some time. There's the bleeding site. This is where it's sort of collecting. The uterus is all boggy, and here we are now with doing the angiogram, and so we're going into this artery to start, and you can see a little bit. This was on the pelvic arteriogram. You can already see a little bit of contrast here, which corresponds to the CT scan. And here when they're in the left uterine artery, and now you can see there's a big blob here, and we go ahead and embolize it, and that's what it looks like afterwards. Now, this was another patient who came in. She had continued bleeding after she'd had an emergency hysterectomy. And here you can see, you know, you don't really, sometimes the sutures can come loose, or the ligatures. So sometimes you can have bleeding from the uterine artery, but you can see that when we place the catheter, we put it up higher, up in the aorta. And here you can see this right ovarian artery coming down. This is just from the aortogram, and you can see the bleeding site. So we knew right away that not to mess around worrying about the pelvis. We would just go right to looking at the ovarian artery. And here we are with a catheter into the ovarian artery. The one thing that's really difficult about ovarian arteries, you can see how squiggly they are, and it's very difficult to get a catheter down there because it'll go into spasm, and then you can't get anything going through. And here you can see the bleeding that she's had, really quite massive bleeding. So what we did was to put in a microcatheter a little bit down into here, maybe a little bit farther, and then we put in some coils. And I think we put in some particles first to let that get carried downstream. And then we put in some coils after that and stopped her bleeding. So most of the time, when you have postpartum hemorrhage, it's primary, about 75%. Most of the cases that are primary are atonic uteruses. Most of the cases of secondary PPH are retained placental fragments. The technical success for this is very good. Pretty much 100%. The clinical success rate is a little less, about 95%. 5% of people in this article that was written in 2011 had to undergo hysterectomy, but it really is important to tell the gynecologist, just like I showed you with that ovarian artery having to be embolized, that repeat embolization is effective. And one of the things that one wants to do when you do a repeat embolization is to make sure that you've evaluated the ovarian arteries. Now, I want to talk a little bit about invasive placenta, because this is a big deal and something that we can really help with. What can happen, and this happens most commonly with women who've had multiple cesarean sections, is that the placenta becomes stuck on the wall and kind of grows into it. So the least invasive is what's called an accreta, where it invades into the endometrium. Then you can have an increta, where it goes farther in, so that it's really in the myometrium, as you can see up here. And then you have a percreta. And in this case, and these are the really dangerous ones, these are ones that grow out through the uterine wall and start to invade other structures in the pelvis. And these can be absolutely life threatening. It's the leading cause of emergency hysterectomy. The interesting thing is this used to be very rare, but as we've done more and more cesarean sections, it's now estimated that 1 in every 500 women may have this, and it may even be less than 500. It may be 1 in every 350. In cases where you don't treat this ahead of time, you can lose over 3 liters of blood intraoperatively, requiring obviously blood transfusions. And there's about a 7% more maternal mortality from this. As I said, mainly C-sections are the problem, and you will always see, or almost always see, a placenta previa. Sometimes if you have somebody that had some other kind of surgery, like a myomectomy, potentially the placenta can be stuck there and growing through the wall there. But usually it's down at the bottom in this region of the cesarean section. If you get an early ultrasound, you see that there's a placenta previa. If you have a history of previous C-sections, you have to become very suspicious. And oftentimes we'll get an MRI to evaluate the extent. And here you can see, this is an MRI. This is the baby here. This is the placenta down in here. And now it's growing through the wall of the uterus and into the bladder. And that's probably the most common place for it to go. What we've been doing recently is, over the last couple of years, is that we do these in what's called a hybrid OR, so that we are there. We have the patient in the operating room with a C-arm. We go ahead and put sheaths in the, sheath in the groin. The patient then is prepped and undergoes the cesarean section, and they get the baby and take the baby off to make sure that it's okay, because usually these are a little bit early. They try and deliver them between usually around 32 to 34 weeks, because the longer they go, the more problems you have with it. And then they will stitch up the uterus and stop, and we will go ahead and put a catheter in. This is the angiogram, and you can see all of this vascularity. This is all placental tissue that's being filled with this. And then what we'll do is to go in and we'll start embolizing. And the thing that is most remarkable about this is these placentas act like a tumor, and they recruit blood flow from all kinds of vessels. So sometimes we may embolize 5 or 6 or 7 arteries on one side and another 5 or so on the other side, because all of these vessels just get recruited into this abnormal placenta. And this is just this would be before and then an after. So now all of that hypervascularity has been taken away. Up here, you can see the ovarian arteries filling, but they can deal with that because they can clamp those and prevent bleeding from that. So that has been amazingly successful. As a matter of fact, I was thinking about this talk yesterday when I was going to work, and I was thinking the nice thing about doing postpartum hemorrhages is it's one procedure where you've saved a life. And not only have you saved a life, you've also saved a family. So that baby that was just born now has a mother, and the father now has a partner, and it's like just an amazing thing. And I walked into work yesterday, and one of my nurses came up to me and grabbed me and said, "I've got to tell you, a mother of a girl that's in my son's class asked me what I did." And I told her I worked at UCSD and I worked in interventional radiology. And she said, "Oh my God, do you know Ann Roberts. And I said, Dr. Ann Roberts. And I said, and this woman said, yes, I do. I work with her. And she said, she saved my life. 5 years ago, she saved my life. And my daughter is turning 5 on the 28th. And every year I think of Dr. Roberts because I'm still alive with and doing things with her. You guys have to tell me when I have to stop. Anyway, let's talk a little bit more about a late problem, which is in what we call a uterine AVM, although it's really not an AVM. An AVM is a congenital lesion. This is really an arterial venous fistula, and usually occurs after some kind of uterine manipulation, a DNC, a TAB, a myomectomy. It can be a delivery. And these patients present with bleeding, and they have an ultrasound, gets an ultrasound, and it shows all this vascularity that's in here. And when you do an MRI, you can see lots of vessels in here and early filling of the vein. And when you do a angiogram, now you can see here, even on the pelvic arteriogram, that here's all of this vascularity coming off of the left uterine artery. And this is the same thing here, and you can see these draining veins going across over to the other side. And these we treat differently. We don't treat them with a gel foam embolization. We treat them usually with glue or with onyx, another liquid embolic. And here's just another picture. Obviously, I love these pictures. And so this is what it looked like after embolization. And it's a little hard to see, but there's some glue in here that went right into the malformation. And then usually what we need to do is to go over to the right side. And we usually treat that side as well, because it can go across and refill. So here you can, this little gunky stuff down here is the glue. And so that just gives you an idea of how it looks. It's very effective. It's about 96% avoids a hysterectomy. So these patients will oftentimes go on to have another child or a child. Some people use bilateral catheters. I don't think that really is particularly helpful. And pregnancy is pretty common. I've done a number of these, and I've had several women who wanted to get pregnant who were able to get pregnant following this. Am I still okay? Okay, uterine artery pseudo. I can stop anytime now. So you tell me when I'm running out of time. Uterine artery pseudoaneurysm is an uncommon cause of bleeding. It's due to trauma. Again, it's C-section, but other surgeries or deliveries can also cause this. This is a little bit unusual in that it can develop even what appears to be years after what would be a probable incident. So it doesn't necessarily occur right away. It depends on where it is with relationship to the endometrial canal. This was a 28-year-old. Couldn't find a case of my own for this. So this is from the literature. You can see this on ultrasound. She came in with bleeding, and now she's got this pseudoaneurysm. You really don't need to do probably all of this, but this is what it would look like on CT. This is what it looks like on MRI. So it's a nice case that shows all the modalities where you might see this. And you go ahead and do very much like you did before, is to go into the uterine artery, usually with a microcatheter, and then embolize that. This one was embolized with coils. You could also use glue or onyx, and then they gel foamed it, and then they embolize the other side, because you get a lot of cross collateralization in the uterus. So you want to make sure that you can get both sides as you need it. Okay, actually, that will do it for me. And thank you for inviting me to talk, and I really enjoy it.